Welcome, everybody. So let's get right to it. My name is Dr. Chad Duplantis. I'm a restorative dentist from Fort Worth, Texas. Am I a laser expert? I wish I was, but I use a laser in clinical practice and I feel to know a good deal about them. I have a couple lasers in the office. Just disclosure for this evening's program. I am the co-founder of a group called Dentists in the Know. I'm a key opinion leader for several dental corporations. And I may share some of the products that I use throughout my practice, but I don't receive any financial remuneration based on sales or service. Today's lecture is supported by my good friends at Shofu from Carlsbad, California, and it's good to see you all here tonight. And I'm honored to be part of this presentation. I'd also like to thank my good friends at Catapult Education. Dr. Lou Graham has just done a wonderful job of creating Catapult and doing all the various things, promoting education. He's got a great GPO that they're working on right now. And so thank you to Lou and your team at Catapult. I really appreciate you all inviting me to do this presentation tonight. Following tonight's presentation, my shameless plug is that I run a group called Dentists in the Know. It's a Facebook group, it's an Instagram group, it's a YouTube group. We do a weekly show, we have a podcast. I'm on Facebook, I'm on Instagram, and there's my email right there. If you use that QR code, you can contact me with any questions that perhaps I don't get to tonight. But I have an open door policy, and I promise that although it may not be expeditious, as busy as we've been lately, I will get back to you. So please feel free to email me. And if you want any information from tonight's presentation, I'm happy to share that with you. So let's get right to it. Let's talk about lasers in dentistry. And for those of you that may or may not know this, laser is actually an acronym for light amplification. Good gosh, if I can talk tonight. Light amplification by stimulated emission of radiation. So when we look at lasers, there's a lot that lasers can do in dentistry, but over time, as far as for cutting procedures is concerned, in the 1800s and even today, we still have the scalpel. In the 1920s, they came out with this wonderful invention that they thought was the end-all cure-all called the electrosurgery. And I believe it was 1964 that we saw the first introduction of lasers in dentistry. And I believe that that's where it all changed. Lasers in dentistry have been a fantastic introduction to our clinical armamentarium. Over time, there are multiple applications throughout medicine in general, dentistry just being one little part of it. And if we look at lasers, the same lasers that we use in dentistry are used to treat a variety of medical conditions. When we think about how lasers are actually used in dentistry, there's multiple ways, and I'm going to go through several of them tonight. We have excision of lesions. We have pigmentation removal, those nasty amalgam tattoos. We can do frenectomies, vestibuloplasties, guided tissue regeneration, gingival recontouring, ponic site preparation, troughing, orthodontic hyperplasia recontouring, orthodontic exposure, a distal wedge procedure, direct pulp capping, removal of granulation tissue. We can treat periimplantitis. We can expose implants, and we can do laser-assisted periodontal therapy. Now, one of the things that's very popular in dentistry that I'm not going to get to tonight, because I'm just going to go ahead and tell you that I'm not the expert on this, but I can certainly point you in the right direction of a course for you or your hygiene department, is periodontal or hygiene applications. We can treat periodontal disease. We can treat isolated periodontal pockets, periodontal abscesses, aphthous ulcers, herpetic lesions. I will talk about both of those this evening, and we can desensitize dentin. So the moral of the story is that lasers are a very multifunctional technological advancement in dentistry. And I truly believe in multifunctional technology, and lasers are just that. But one of the things that we need to understand about lasers is laser physics. I think it's something that we all need to understand. It can be rather complicated, but I'm going to try and break it down and make it a little bit simple for you. Why is laser physics important? It's because us as dental practitioners need to understand and be able to predict the tissue interaction with the laser. We need to be able to determine the appropriate therapy. We need to be able to confidently perform procedures. And we also need to be able to, it doesn't state it on this slide, but we need to be able to adjust the settings to achieve the results that are intended for our patient population. So when we talk about laser physics, the most important factor is light energy. We talked about, what lasers mean, and the first word in laser is light. The second word is amplification. So light energy is very important. So how do lasers work? Well, there are these atoms that are stimulated and excited by an outward energy source in which the electrons absorb. The electrons then become excited and then they relax into their original state. And the absorbed energy is released in the form of a photon or a light particle. And the photon is then transmitted onto the tissue or recipient. How do we do this? Well, there's three components of a laser. The first is the medium. This can be gas, a solid, or a liquid. And these are the atoms that release the photons. The second is the exciter mechanism, which is the outside energy source that acts upon, number one, the medium, light, heat, radio frequency, which begins the process of stimulated emission. And once the photon is released, the process begins to replicate. And then finally, there's an optical resonator, and this amplifies the photons from the stimulated emission. And as the photons begin to travel around at the speed of light, the overflow exits one into the tube and onto the tissue. And so, real simply stated, you have a rear mirror reflector, you have a front mirror, which is a partial reflector, and the output coupler. You have the laser gain medium that excites the electrons, and then they begin to relax, become photons, and then they release the laser beam. Now, once that laser beam is released, there's additionally three unique properties of laser light. Laser light is monochromatic. So each photon released is the identical wavelength. CO2s, for example, are 10,600. Diodes are 810 to 980 nanometers. And therefore, if we understand the wavelength, we can accurately predict the tissue interaction. You'll see that in just a minute. Laser light is also collimated, which means that the laser light travels in a beam that is strong, it's concentrated, and there's little to no divergence of the beam. We'll see that as well in just a minute. And this allows that laser beam to focus on a very precise location. And finally, laser light is coherent. Each photon moves just like a group of soldiers walking. They're in step with one another. They're in phase in both space and time. And so when we look at it, a regular pulsed light, if you think of a spotlight that we used to see as we were kids, it's non-chromatic, it's non-coherent, and it's defocused, and it bands out as it goes up. Laser light, in contrast, is very monochromatic, it's very coherent, and it's very collimated and very precise. So it allows us to precisely predict the tissue interaction once again. Now, there's several types of lasers in dentistry. We have gas lasers, we have solid state lasers, and then we have a semiconductor laser. And the laser that we're going to talk about this evening is a diode laser, which the construction is of a semiconductor. The delivery system is through an optical fiber. And diode lasers are mainly used, well, I shouldn't say mainly, it's all for soft tissue interaction, and we'll see why in just a minute. The diode laser that we're going to talk about operates in the 800 nanometer wavelength range, but they range once again from about 810 to 980, and you can see some for less and some in between as well. Important factor number one was light energy. Important factor number two is absorption. So that light energy, what happens to it is it's absorbed, and therefore we get the tissue interaction. In order to understand absorption, we need to understand what a chromophore is. And a chromophore is a substance or a molecule capable of absorbing specific laser wavelengths. And the main chromophores for ablation and coagulation of oral and soft tissue are oxyglobin, oxyhemoglobin, hemoglobin, melanin, and water. And we're going to learn a little bit more about those is in just a few minutes. But when we think about absorption, we really need to understand these chromophores because the various lasers work on different chromophores within the tissue. And so light energy and absorption lead to the intended or desired effect of any particular laser. So tonight's presentation is on diode lasers. I also have a CO2 laser in my office, but the diode laser, we'll get to it as we speak, is something that I cannot live without in my clinical practice. Once again, the wavelengths range from 810 to 980 nanometers. They're easily absorbed by chromophores, and the chromophores that are absorbed by the diode lasers are hemoglobin and melanin, but they are poorly absorbed by hydroxyapatite and water. Therefore, this is not a good hard tissue laser. As a matter of fact, it's not going to have a desired effect on hard tissue because it is absorbed by hemoglobin and melanin. These lasers have a very shallow depth of penetration, and they may, for certain procedures, as a matter of fact, the majority of procedures, they will require activation of the tip, which once again, we will talk about in just a few minutes. So when we look at the various lasers on the market, we need to look at the light spectrum. On the left, you have the invisible or ionizing radiation. Between 350 and 750 nanometers, you have visible radiation. And to the right, we have invisible or thermal radiation. And you can see that the various lasers operate at different wavelengths, which we'll see in the next slide becomes very important. And the diode, once again, is between 810 and 980 nanometers. And when we look at the absorption coefficient of various chromophores, we can see that the two that have a positive absorption coefficient for the wavelengths of diode lasers are melanin and hemoglobin, and the two that are poorly absorbed are hydroxyapatite and water, which once again tells us that this is truly a soft tissue laser. And as we go further up the chain, we can see that some of our other lasers on the market are more hard tissue lasers, which we hear all about, the painless cavity preparations and the removal of hard tissue. And as they go up in their abilities, of course, they're going to go up in price as well. So what are some of the advantages of dental lasers? And these are all of the dental lasers. It's a relatively bloodless surgery, and you'll be able to see that as we go through some clinical presentations at the end of my presentation tonight. There's minimal swelling, there's minimal scarring. We get coagulation as we cut. There's no need for suturing. There's a reduction in surgical time, and there's less or no postoperative pain. And I can tell you that from experience, this is certainly the case in the majority of the procedures that we do. We very rarely have a patient come in and say, "Oh, that really hurts." As a matter of fact, when I call the patients the evening of the laser procedure, they're not in pain. The next day or 2 days later, we talk to them. We usually follow up on the larger surgical cases a week later, and these patients all tell us that they had minimal postoperative pain, if any. And so the majority of them will tell us that they had no postoperative pain, which as a practitioner, we all know is wonderful, because if we do a filling and they hurt afterwards, that's not good. But if we do a surgical procedure and they don't hurt afterwards, that's wonderful. That makes my job easier. That makes your job easier. So I want to do something that's going to have a positive intended effect with minimal negative effects on the patient as far as pain. When we cut with lasers, the laser instantly disinfects the surgical wound, as well as allowing a non-contact type of operative procedure and therefore no mechanical trauma to the tissue. And so diodes are a little bit different because there is a contact component of it, but still we get instant disinfection, and we get minimal mechanical trauma to the tissue. And it's a very wonderful feeling to be able to have that as both a patient and as a clinician as well. One of the things I want to bring to light is because I know that a lot of people are out there are still utilizing the electrosurge. And although the diode cuts a little bit differently, it acts like an electrosurge, but it's much more efficient and much less traumatic to the patient. So when I first switched, and granted, I've been doing this for 25 plus years, when I first switched from an electrosurge to a diode, um, I wondered why we were actually doing this. And so let's take a comparison of these two procedures. When we compare the diode and the electrosurge, the diode is very precise because of that collimated laser that is directed towards the tissue. We get a very precise tissue interaction. And the electrosurge lacks the precision that the diode has. Diodes can be used without anesthetic in certain situations, and the electrosurge most always requires the need for an anesthetic. Diodes have minimal thermal damage, and the electrosurge has a more considerable amount of thermal damage. Now, when we talk about recession, diodes have little to no recession, and that's because their depth of penetration is 3 to 5 cells deep, and the recession is more prominent in an electrosurge because they're more like 300 to 500 cells deep as far as their depth of penetration. Diodes are safe around metal, and that's why we can utilize these to uncover implants and so on and so forth. Whereas the electrosurge, it's not to be used around metal. And so this makes our life a lot easier, especially if you're uncovering an implant. Even if you don't place implants and the patient comes over, they're ready to restore, you need to uncover it, feel very comfortable utilizing your laser. And finally, diodes can be used for treating minor periodontal and endodontic issues, whereas the electrosurge cannot. So when we think about it, the diode is really a much better tool to use in clinical practice. Now, for those of you that utilize an electrosurge, I don't want you to think that I'm knocking you. In my hands, I feel that a diode is better for my particular patients. But I always ask when we consider a diode versus an electrosurge, for those of you that haven't been doing this as long as I have, you may not remember this, but when you use an electrosurge, would you rather ask your patient that they need to be grounded or tell your patient that they need to be grounded prior to utilizing the electrosurge? Or would you like to just ask them to put on a pair of safety glasses? And in my practice, it seems as if the diode always wins versus the electrosurge. And I'm very pleased that we've been utilizing the diode in our practice for as long as we have. Once again, I've been doing this for 25 years, and I believe that we've had a diode in our practice since as early as 2002. We've gone through several renditions of it, and where they are today is absolutely fantastic to where they came from where they came from. The diode has been a great addition to our practice. Now, let's talk about the Denalays from Shofu, which is a relatively new diode to enter into the market. This diode is a lower power compared to some of the others on the market, but it has a 3-watt constant power, or it has a 5-watt pulsed infrared power. It operates at 808 nanometers, and the power capabilities combined with the scratch-resistant chassis of the diode provide clinicians with a powerful tool for soft tissue procedures, including gingivectomies and frenectomies. And that's the majority of what we're utilizing this for in our practice is gingivectomies and frenectomies. This is what the Denalays looks like. And I've used many lasers in my practice, but one of the things, there's a number of things I like about it, but it runs continuously for 45 minutes on a single charge. It's got a distinctive green aiming beam for better visibility during procedures. It's got a nice handheld ergonomic design, which is perfect for anterior and posterior applications. I haven't found a place in the mouth that I can't utilize this for. And it's got a very intuitive push button interface. It's wireless, it's durable, it's made out of aluminum. Now, one of the things with diodes, I don't see these very much anymore, but these have disposable fiber tips, which saves time and prevents cross contamination. Some of them have an optical fiber, which needs to be cut, which I guard against. But if you're going to choose a handheld diode laser, I would always recommend that you choose one with a disposable tip. Yes, there is a cost incurred for each patient, but it's not much and it's well worth it in the end. And this has a very minimal footprint. As a matter of fact, when we got it, uh, in the box for our practice, I told my assistant, I said, you're going to need to remove several things behind the patient so that we can fit this here. We opened up the box and we set it out there, and it's a very, very minimal footprint. It's smaller than a portable phone. I mean, it's maybe a 2 to 3 inch diameter pedestal, and the laser sits right on there and it charges continuously. And once again, it runs for 45 minutes when you take it off the charging station. So there's a number of great features that come with this dental A's that have been a great addition to our practice. There's a quick guide that comes with it. One of the most frustrating things for dentists is figuring out how to work the technology that comes through our office. But I promise you that if you read the directions, it makes life a lot easier. These directions are on a little laminated card. They can sit right behind the patient. There's so many technological advancements that have come through dentistry that it's hard to keep up with all of the technological advancements and how to operate all of the technology in our offices. However, this has a very quick and easy to use guide. There's a lot of button pushing that comes with it, but you can utilize the quick guide to just turn it on. It stays in a standby mode. You can alter between the continuous or the pulse mode. And then it shows you when it's ready. And then you just fire it right from the handpiece rather than having a foot pedal. One of the things that I will say, and this is in reference to all dental lasers, is um, various states have different certification requirements, but most states do have requirements that you need to post a sign that the laser is in use because it does emit a form of radiation. You need to have the patient wear safety glasses as well. And all of those items come with the laser and they're ready for you so that your office can be prepared for the procedures that you're going to be doing with the laser. Now, another thing that's nice about this does not eliminate the need for training with a laser because I highly recommend that all dentists become trained utilizing a laser in their practice. But for the various procedures that you're going to do in your practice, you'll be able to see the procedure, the mode, the power, the technique, and whether or not you have to initiate the tip. And we'll talk about that in just a second about the initiation of the tip. So what you'll see is for the various procedures, you have a CW, which means that it's utilized in continuous mode, or you have a pulse, which means that it's utilized in the pulse mode. Now, the difference in those two is on the continuous mode, it emits the same amount of power throughout the procedure. On the pulsed mode, it's on, off, on, off, on, off, on, off. So basically, what it allows the tissue to do in a pulsed mode is the tissue goes through a process called thermal relaxation. So it's hit with the power, and then the laser turns off, the tissue relaxes, and then it's hit with the power again. So if you read the settings up top, it says to achieve the same rate of output in the pulse mode, double the power from the continuous watt mode. So if you want to utilize it in pulse mode, and the more you learn about lasers, the more you'll learn about the pulse mode versus the continuous watt mode. But if you want something to work, efficiently in both modes, double the power from continuous to pulsed, and then you'll allow for the tissue relaxation. Now, let's take a look at the tip. One couple of things that I want you to look at with the tip is you have this metal portion here. I don't know if you can see my mouse. I hope you can, but you have this metal portion. And then at the very tip, you have a glass or a quartz portion. The metal portion can be bent, so it can adapt to the certain areas of the mouth. The glass portion cannot be bent, so you want to bend it from the metal portion so that it'll adapt to the region of the mouth that you're working in. Now, when we talk about initiation, initiation becomes very important because if we look, you'll see that certain procedures require an initiated tip and certain procedures require a non-initiated tip. So when we talk about tip initiation, this is a material such as ink, articulating paper, or cork is placed on the tip of the laser fiber. This prevents the laser energy from exiting the handpiece. This material causes the laser tip to heat up. In this manner, the diode laser is no longer acting like a laser. So it sounds counterintuitive, but a diode laser really acts as a very subtle electrosurge. Because the laser energy is converted to pure thermal energy, the practitioner isn't using the light to do the work. You're using the handpiece as basically a hot quartz tip. So once again, it sounds kind of counterintuitive, but when you're initiating the tip, you're utilizing that tip as a hot tip to perform the intended action on the tissue as we work through it. Now, what we utilize in our practice to initiate the tip is AccuFilm. And just due to the nature of imaging this, I actually just put a little black dot on there. This is exactly what the laser tip looks like when it's initiated. It has just a little black dot on the tip, which means that it is initiated. That's where the laser energy is going to heat the tip, and that's going to cause the intended reaction on the tissue. Now, this picture on the right shows us what happens when the laser interacts with the tissue in a touch mode. So the very first layer is going to be vaporization. The second layer is going to be coagulation. And the third layer is going to be biostimulation. And I want to credit Dr. Gregory Kurtzman. He is a fantastic writer. He's written numerous articles, and this comes from one of his articles. And basically what happens is the laser proliferates the mesenchymal cells without any DNA alteration. So the wound healing is enhanced at the cut soft tissue edge by stimulation of the fibroblasts, which induces growth factors. So that's the biostimulation. So thus, you get enhanced healing at that laser edge from the biostimulation. So once again, 3 to 5 cells deep, you're not going to get much recession. You're going to get some biostimulation, and you're going to get a really nice healing of that site. So with that, let's move forward and let's look at some clinical indications as we utilize the laser in clinical practice. Now, this is something that I receive nothing from. I have no relation to this pharmacy, Carrie Boyd's Pharmacy, but this is something that I really want to talk to you all about because this is a wonderful compounded topical. Carrie Boyd's just happens to be in my area. They're in Irving, Texas. They're a fantastic compounding pharmacy. They've gone nationwide, if not global. And this is the topical anesthetic that we utilize in our practice. Now, why do I bring this up? This topical is 10% prilocaine, 10% lidocaine, 4% tetracaine, and 2% phenylephrine. I bring this topic up and this topical up because a lot of the procedures that we perform can be done with just topical anesthetic. That's not all procedures, and it's very patient dependent. Now, one thing that's very important about this topical is this stuff is so strong that it is wonderful. I utilize this for blocks. I utilize it for small laser procedures, definitely aphthous ulcers and herpetic lesions. but this topical is so strong that if I utilize it for a block and I let it set in the patient's mouth and they swallow some of it, it can actually create an effect on their vocal cords, and they can aspirate saliva, which makes them cough and can lead to other things. So make sure that you control the topical, dry the tissue, place the topical, make sure you have someone there, if not yourself, maintaining suction, and just try to avoid the patient swallowing this topical. But if you use it correctly, this is one of the best additions to our practice over the past several years. I'm a huge fan of topical. I'm a huge fan of painless injections. And I promise you, if you utilize this stuff, you will truly get painless injections in your practice, and you'll get profound anesthesia prior to injection if you even need to inject. And a lot of the procedures that we do, we can just use topical alone. So what I did on these procedures is I broke down the procedure that we utilize the laser for, and I broke down the ADA codes. So the first is for gingivectomy or aesthetic recontouring. D4211 is for 1 to 3 contiguous teeth. D4210 is for 4+ contiguous teeth. So let's take a look at a couple of these cases. When we go back to our little cheat sheet that came with the laser, we can see that for a gingivectomy, it's continuous mode. 1.5 is the power level. It's a contact procedure, and it requires an initiated tip. So you want to utilize your AccuFilm. You can also utilize a cork. Basically, you're going to place that tip up against the AccuFilm or up against the cork at the desired output. You're going to activate the tip, and you will in turn notice a little charring or a little black dot at the end of the tip, and that means that the tip is initiated. So here's a patient that came in post-orthodontics. You can see that we've got altered passive or altered active eruption. On this particular patient, what I did, this is pre-printing times, but I just went ahead and I mapped out my procedure on some stone cast as to what I was going to do. With this, if you want to alter the cast as you will, or sometimes I can do this with a diagnostic wax up, make an Essex retainer, and I'll just mark the areas. If you look above the cuspid, what I did is I marked the height of the zenith above the cuspid. And that's where I know that I'm going to extend that laser cut, if you will, to. So here we are, we're starting at the central region. And one of the things that I want to note with this is any laser procedure that we do might require a touch-up. This is something that was done utilizing a topical and local anesthetic. It's done with an initiated tip. The tip is in contact with the tissue. And one of the things I want to point out is when you're doing a gingivectomy procedure, you want to make sure that you maintain a uniform direction. The other thing that I want to point out is that you want to constantly have your assistant holding suction over this, and you want to also constantly be cleaning the tip. You don't want that tissue to get gummed up on the tip, because all that does is it extends your depth of cut. So constantly have the assistant have a moist 2x2, removing the tissue off of that tip, and always look at the tip. If you've lost your char mark, it needs to be reinitiated. But this is done with just a gentle sweeping motion, cleaning the tip frequently, and I determine my direction. And so I'm going to go towards the distal of the arch, and that's the direction that I'm going to maintain. I'm just going to constantly sweep that tissue. So here we are immediately post-operatively. You can see we did the majority of the recontouring on the lateral and the cuspid, and then we went as far back as the second bicuspid. And here we are a couple weeks post-op, and you can see that in this particular case, I got a little bit of rebound on the laterals. So if the patient's not happy or you're not happy, you may have to go back and touch this up. Now, one of the things we need to keep in mind is biological width. And so we have a lot of keratinized tissue on this particular case. What I'll do before I do these cases is I'll sometimes go in with a periosteal elevator, and I'll just release that periosteum. Of course, the patient's anesthetized prior to lasering. And then in this particular case, If I'm going to redo the laterals, I'll just release that periosteum again. I'll make sure that I cut because the biological width will rebound, if we don't maintain that. So make sure we have good keratinized tissue, make sure we release the periosteum if we need to, cut, and then, like I said, sometimes you're going to need to touch up. In this particular case, the only place that I would see that we needed to touch up is on 7 and 10. If the patient's happy, sometimes they refuse. And this particular patient is 16. She was done. She's going to refuse. And so we'll just continue to monitor this particular patient. Here's another case where the patient came in. The patient broke the palatal cusp. How many times do we see that in our practice? On tooth number 4 there. And so whether we're going to repair this with a crowned restoration or a partial coverage restoration or temporarily repair this, which is what we were going to do in this particular case, I want to expose the margins. So I came in with a laser and I exposed the margins, removed that gingival tissue. Very, very easy to do on these particular cases. And then here's one where we're going to walk through the entire procedure. And this is something that maybe you can relate to. This is not your ideal patient. This is an 85-year-old female. She's a longtime patient. She needs transportation to our office due to her inability to drive. So when she comes in, sometimes what you see is what you get, and you got one chance to get it done. Otherwise, you're calling on somebody to come in and help this particular patient. She broke tooth number 12. And she wants us to see her to see if we can fix the tooth. When she arrives, once again, something you've probably seen in your practice on numerous occasions, she had an MOD alloy on tooth number 12. She fractured the facial cusp in this instance. Here we are from the occlusal view, and you can see that that gingival tissue, we know that that rebounds very quickly. So we can take this particular case and we can say that this is what happens sometimes when we lose a crown. This is what happens, sometimes when we break a cusp, but this is something that we see on a regular basis. So in this particular case, we went ahead and we prepped this patient for a partial coverage restoration where I'm going to cover half of the palatal cusp and the entire facial cusp. We went and used our laser to remove the excess dental tissue. And here we see it's very charred at this point in time. Sometimes it looks very charred, other times it doesn't. One thing I want to point out on this is that if you see a patient with very, very pink tissue versus very, very red tissue, you may need to adjust those settings. We need to understand the amount of, hemoglobin or the amount of vascularity of the tissue. The red tissue is going to require maybe a lower setting. The pink or the whiter tissue is going to require a little bit of a higher setting. So the tissue looks a little bit charred. In this particular instance, you can take a little cotton pledget with just water. You can use hydrogen peroxide if you desire. In our practice, we utilize a little chlorhexidine. We scrub that area. And here we go. We've removed the tissue. We've got exposed margins. We got a nice impression of this. We designed the restoration, and she was able to leave that day coming in from a fractured facial cusp, like, can you please help me? Let's do something. We knew that we had a one and done chance, and we were able to do everything with minimal discomfort to the patient. And there's the final restoration. And the beauty of this is that from start to finish, by utilization of the laser, we had easy cutting, we had a lot of coagulation, we had a great result, and from start to finish, this procedure took me 57 minutes. So how fantastic is that? That's a wonderful way to be able to treat your patients and especially take care of your patients. Now let's talk about herpetic lesions and aphthous ulcers. Now, we'll talk about this in a few minutes. Some of these procedures are going to make you money and some of them aren't. So for herpes labialis or a herpes lesion on the lip or vermilion border, our code is going to be D7465. And for an aphthous ulcer, it's going to be D7410. Whether you charge for this or not, that's entirely up to you. There's recommended fees for these certain procedures. but I can tell you a lot of times our hygienists, as well as myself, are trained in laser therapy. And this is something that if we've got the laser, it's so easy to snap a tip on it. It's a practice builder. Just, hey, you got an aphthous ulcer, put a little topical on it, let it sit for a few minutes and treat it. So as far as herpetic lesions are concerned, these are best treated in the prodromal phase. And if you're not sure what that is a patient who gets these regularly can dang sure tell you what the prodromal phase is. It's an itchy or tingly sensation that the patient feels, and they know that they have one of these coming on. So if a patient is in your practice and says they have one of these coming on, this is a great procedure to try on a patient and just say, hey, let's see it. If we can treat this with the laser. And in the majority of instances, if you hit it once with the laser, these may never come to fruition. And in the case that I'm going to show you in just a minute, it never came to fruition. Patient forgot about it. Patient was in a week later, never saw the lesion. So the laser basically acts in the final stage of herpes simplex virus 1 replication by limiting the viral spread from cell to cell. And laser therapy also acts on the host immune response, unblocking the suppression of the pro-inflammatory mediators induced by accumulation of progeny virus in infected epithelial cells. So that's a lot of jargon saying that it basically just stops this at its source. Now, these can be treated in contact or in non-contact mode. Herpetic lesions and aphthous lesions have two different settings. In the herpetic lesion, you're going to use it in a pulse mode, 1.5 watts of power, non-contact on a non-initiated tip. So this is something that you're utilizing a non-initiated tip. Now, on aphthous ulcers, the recommendation is continuous watt, 0.5 watts, non-contact, non-initiated. The more you do of these, sometimes I just like to zap them with an initiated tip in a contact mode. So on aphthous ulcers, you can do contact or non-contact, but on every herpetic lesion that we do in our practice, and you're just going to find what works best for you for aphthous ulcers. But for every herpetic lesion that we treat in our practice, we treat in a non-contact mode with a non-initiated tip at 1.5 watts. So this may require a couple treatments, but you want to do them a few days apart because you have a limited time. Once again, it's best done in the prodromal phase. And I'm going to show you this. Mute this because I don't want you to hear him screaming. No, I'm teasing. The sound's not very good. But basically, what you do is you start 6 to 7 millimeters away from the lesion. You utilize a circular motion. So in this particular case, you can see a counterclockwise motion. You start from from outside the lesion and you work your way into the center. Now you want to do this 6 to 7 millimeters, about 4 to 5 millimeters, and then about 2 to 3 millimeters away from the lesion. So I always do 3 passes. You can do 2 to 3 passes. So the first pass, 6 to 7 millimeters away, and then you work your way outside in to the center of the lesion, and then 4 to 5 millimeters, same exact motion, counterclockwise or clockwise, whichever way you desire, towards the center of the lesion. And then third pass about 2 millimeters away from the lesion. Counterclockwise is what I'm doing here. Outside, from the outside of the lesion towards the inside of the lesion. And once again, on this particular patient, there was the lesion never broke the skin, never had any issues with it. And this was a wonderful way to treat it. Now, one of the procedures that I would anticipate you'll probably be doing most in your practice is a frenectomy. And this is something that we do very, very frequently in our practice as well. The code for this is D7960. When we look at the breakdown for this, a frenectomy is a continuous wave, 1.5 watts of power. It's going to be in contact mode, so that heat is going to be through the tip. It's going to be on an initiated tip, and you're cutting the tissue utilizing the laser. And just like the gingivectomy or the that we saw as the first case, you're going to make sure that as you're doing this, you're always paying attention to your tip and you're cleaning the debris off of your tip so you're not getting a wider cut. So here we are in this particular instance. This is a patient with periodontal disease, and you can see that that mandibular frenum is pulling on that tissue, which can be creating more of a defect in between 24 and 25 than desired. So what we're going to want to do is we're going to cut that, and we're going to want to release that frenum. Now, I always say that these things can sometimes require multiple treatments. And the reason being, on frenectomies, a couple of reasons. If you end up anesthetizing this patient, which we did, what's going to happen when you place the anesthesia? The anesthesia is going to expand that tissue and it's going to create a bolus of anesthetic. And so the frenectomy is going to kind of flatten out. So I want to go as deep as I can. So I'll use a 27 gauge short needle and I'll go as deep as I can and try and get deep anesthesia. And I'll go very, very slow and try and minimize that bolus. And I'll let that anesthetic set for sometimes 15 to 20 minutes and let it dissipate a little bit so I can see and visualize as much of that frenum as possible. Sometimes on these anesthetized patients, you're going to pull that frenum out and you're not going to be able to visualize near as much as you could when you were looking at it with no anesthesia. So that's why these may require multiple treatments. You want to do it with an initiated tip. You want to make sure that the tip is in contact with the tissue. You want to be as close to the bone as or periosteum as possible. And you want to maintain pressure on the frenum to expose as much as possible. So you'll notice that my hand is pulling the frenum out in this particular case, and I'll play this while we're talking here. But you want to make sure that you're pulling on that frenum and tugging on it as much as possible so you keep it as taut as possible. And I know that the lighting's not great on this video, but if you look at the very beginning of it, you can see that I do have a very good visualization of that entire frenum. Allow for ample time for the anesthetic to diffuse and clean the tip frequently. And you'll notice that I'm pulling the tip across towards me, I'm lifting it back up, and I'm coming back over. I want to go the same direction every single time. A simple sweeping motion, and each time I'm cutting and that frenum's releasing. Now, I'm going to tell you, the first time you do this, depending upon the length or the depth of that frenum, it's kind of freaky. You're going to kind of look at this and you're going to be like, oh my gosh, you're going to expect bleeding. You're going to expect a lot of issues. I want you to be careful. I want you to be well trained prior to doing this, but this is a wonderful procedure to be able to do for your patients. So here we are before. Here we are immediately post-operatively. If we look at multiple images of these frenum releases, you'll notice that there's always kind of a diamond look to it. It'll be thinner at the top, thinner at the base, and wider towards that depth of the alveolus. And then afterwards, you're going to want to place some sort of salve on it, and you're going to want to send the patient home with instructions. So here are the two things that I use immediately post-operatively for frenum releases, or for any lesions that I treat in the mouth, aphthous ulcers, anything that requires a cut. I used to use vitamin E capsules. And so what I would do is I would puncture the capsule. I would take the gel out of the inside, and I would apply it in the office with a cotton tip applicator. And I would instruct that patient that I want them to apply that 3 to 4 times a day. And I want them to do a little bit of a lip exercise. I want them to pull their lip out, and I want them to just kind of move it, because the last thing that we want them to do is to heal. And then you not only have a frenum, but you have a vestibule that actually decreased in depth versus increased in depth. So I want them to make sure that they're exercising that lip. Now, the beauty of this is if we look at that picture, that looks like it's going to hurt like hell, right? These patients have zero postoperative pain. Now, I've transitioned recently, and once again, this is another company that I received zero financial support from, but this is something that I was turned on to a few months ago in a Facebook forum. This is a fantastic product. It's called Stella Life. I am sold. I bought a case of it the first time I met with the company. I've ordered a couple cases since. We're utilizing this in our practice. I've switched from vitamin E to the Stella Life gel. Same application 3 to 4 times a day. This is a completely homeopathic, vegan oral gel. It minimizes the need for any kind of post-operative pain. So this is wonderful. I use it under dentures. I use it for frenectomies. I use it for patients with aphthous ulcers. The cost is minimal compared to the relief that they receive. There's a gel and there's a rinse. If the gel is ample, but if you want to use the rinse as well, it's absolutely fantastic because as they're pursing their lips, they're actually getting exercise on that frenum. But I have them just apply the gel just like I would with a vitamin E capsule 3 to 4 times a day. And then just have them exercise their lip, pull it out and back. And that's going to give ample exercise to the lip and allow those tissues to heal the way that they're supposed to. Wonderful, wonderful product. Like I said, don't receive anything from them. I wish I would because I'm using it like water now. The last procedure that I want to share with you, this may not be a money maker in your practice. I don't even know the ADA code for it, but this is coagulation. So when we do a procedure, we need hemostasis. We want continuous wave, 1 watt of power, contact on an initiated tip. So here's a quick case that I'll walk through with you on this. This particular patient came in, elderly patient, once again, one and done, lost a bridge on the upper right, lost the bridge a few days before, and as we know, that tissue rebounds so quickly. So we go to place the bridge back in there. We can't get the bridge to seat. Of course, we could have her place pressure on it. That's going to be rather painful. So you know what I'm going to do? I'm going to anesthetize this patient, and I'm not going to use the laser to create that ponic site. I'm actually just going to use a round, coarse diamond burr. What do we know about that? That's going to create a lot of bleeding. So we come in with an initiated tip. After we've prepped that ponic site, we're going to maintain contact with the tissue. We're going to clean the tip frequently, and we're just going to walk around and we're going to pulse those little bleeders in just a few seconds. Granted, this bridge doesn't look like it has a long lifespan. This patient is elderly. I want her to get as much life out of the bridge. Yes, she knows that it's on borrowed time, but here we are immediately after coagulation. I just take a cotton ball dipped in some chlorhexidine and I just dab it on there just to get any of the debris or the char off of there. We've got a nice ponic site, and boom, we restore the bridge. There's no more blanching. The bridge is able to seat. The patient goes home. The patient is happy, and we're done. So once again, in closing, the laser is a wonderful tool to have in your practice. And one of the questions that I always get asked is, what's the return on investment? And return on investment is something that we need to look at in dentistry, as it's not always measurable. So I have 3 rules that I live by in my practice as far as return on investment is come from. The first is that there are certain things that we need in our practice. We absolutely need in our practice, but it's not something that we need every day. But it's something that when we need it, we want to make damn sure that we have it. So that's rule number 1. Rule number 2 is that there are many procedures in dentistry that we're going to be extremely profitable from and have a wonderful lifestyle and be able to treat our patients. Rule number 3 is that there are also many procedures in dentistry that may not necessarily have a measurable return on investment or profit, but they will make your life easier and they will improve the patient experience. Those 3 rules will make your life and your practice worthwhile. Just understand those 3 things. And so in my practice, I always say what Jeff Bezos said. You may not know him by name or by face, but you certainly know what he did with Amazon several years ago. But he said, if you build a great experience, customers tell each other about that. Word of mouth is very powerful. And in our practice, it's really easy to exchange one word in there. If you build a great experience, patients tell each other about that, and word of mouth is very powerful. When you talk about a few things we talked about tonight, the topical, the use of a laser, the minimal postoperative pain, those improve the patient experience. They create loyalty. They get referrals. Patients love it. That frenectomy that I showed you a little while ago, that patient had 0 postoperative pain. I talked to him twice after that just to make sure. I talked to him the day after and I talked to him a week after, and he said he had no pain. I think it was in part due to the laser and in part due to the postoperative Stella Life that we gave him. But you aren't going to have patients that are having a lot of pain from these procedures if you do them correctly. Now, finally, one of the things, each state is different. Some states require certification. Most states do require certification for hygienists, but get yourself educated. There's several resources. Catapult Education, who's hosting this webinar tonight, they're a great resource. You've got my mentor and one of my best friends, Dr. Ron Kaminer, who probably knows more about lasers than anybody I know. And you've also got a new doctor to Catapult, Dr. John Zielinski. They're both fantastic laser doctors. They can teach you a lot. There's the American Laser Study Club, there's the Academy of Laser Dentistry, and there's the American Board of Laser Surgery. Look into all of those. I provided the websites here. Get yourself educated, get your team educated, get your team excited about utilizing the laser. We certainly love it. We can't live without it. Our patients do appreciate it. And finally, if you have any questions that I don't get to tonight, please, please, please feel free to reach out to me following tonight's presentation. And as I stated before, I promise I'll get back to you. And my final shameless plug is if you get the opportunity, please follow that QR code, download our podcast, join us on Dentist in the Know. Another great laser resource is Dr. Bob Convasar. We did a podcast with him a few months ago. He's fantastic. A lot of what I've learned is from Bob. Um, and I hope that you got at least one thing out of tonight that you can utilize in your practice. The Dentalase from Shofu is a fantastic laser. We've been utilizing in our practice now for almost a year, I believe, and just been super impressed with the capabilities. And so that's all I have. And I'm going to see if there's any questions. And the question was that I have is, why do we need to initiate the tip? So on a laser, as I stated before, on a diode laser, um, you have two mechanisms, non-contact and contact procedures. And on the contact procedures, an initiated tip acts as a hot quartz cutting tip. And so that's why we need to initiate the tip if we need to do anything for coagulation or cutting. It needs to be initiated because it comes in contact with the tissue. And that improves the desired result. Can we see a periodontal procedure for a hygienist? I would prefer that you take a perio hygiene course. We do utilize it in our practice for hygiene. It's something that rather than showing it to you, you're going to see the results in those post-operative and those follow-up appointments where you see the reduction or elimination of the pocket depth. And so I would prefer that you take a periodontal or hygiene related course for lasers. When the tip is sweeping, do you aim it perpendicular to the tooth and tissue or at an angle? I always aim it perpendicular to the tissue that I'm trying to cut. So if I'm doing a gingivectomy, I'm going to aim it really parallel to the tooth, perpendicular to that tissue that I'm trying to cut, or really kind of at an angle. So it just depends. You're going to find it's not going to have a negative effect if you hit the tooth because the tooth is not affected by a diode laser. Now, on other lasers, it will. So it's very important on the aiming, but you're touching the tissue. So when you're touching the tissue, it's whatever angle you can get to the tissue at. And it's usually parallel to the tooth or at slightly maybe a 30 to 45 degree angle off of the tooth. When exposing the implant top of the laser, do we remove the tissue with the laser right over the implant? There's a number of ways to do it. What I would try and do, it just depends on if you can visualize where the implant is, but I would try and sound it with a probe, with a periodontal probe, and I would actually walk around the top of that implant and I would try and go around the implant as much as I can versus right on top of the implant because you don't want to deliver any heat to the implant. Although it's safe, I would try and go around the implant perpendicular to the tissue and try and uncover that implant. Should we use alcohol or water to clean the tip of the laser during a soft tissue procedure? And in my practice, just water on a 2x2 is fine. Does troughing around a crown prep replace or complement cord? That's a great question. I would say that it depends on the procedure. Troughing around the crown can sometimes replace the cord, and sometimes troughing around the crown uh, will complement a cord. Um, And I do that in certain instances, but most of the time, I would say in my clinical practice, it replaces the cord.